I wanted to talk to you a little bit about what can we do a little bit more than just those simple activities that you may or may not be aware that we do as occupational therapists. So that is my role today, is to talk to you a little bit about some of the courses that I've been to in the past year that I think are affecting Parkinson's, that are actually relatively impacting a lot of people that I've been working with lately. And some of you, we've talked about this, so sorry if I'm double dipping on any of this. All right, so just to tell you who I am, I'm Heather. I'm one of the occupational therapists at the Center for Movement Disorders. Come on in. I don't bite. Oh, yet. Yep. I'm Heather. I graduated from UF, born and raised in Gainesville. Can't get out of this place. I like it. And I worked in outpatient neuro and then outpatient pediatrics. So I kind of have a kid mindset. So if I seem a little goofy, that's why. But I also find that you adults are goofy too. So I like it. I do specialize in movement disorders, but I also specialize in Tourette's syndrome. And what's interesting with Tourette's is that there's a lot of psychiatric comorbid conditions within that, and that is stress, anxiety, and I found when I started taking a lot of courses within that, it correlates a lot with Parkinson's. And so that's where, when I started researching that, it really carried over into what I was doing with Parkinson's works, and that's where this topic started to come in. On the team, this is who I am, okay? I am the occupational therapist in this big bubble. I should be a part of the group. Can you see okay? Okay. So I'm the occupational therapist in this mini group of fabulous people. There's neurologists, neurosurgeons, psychiatrists, social workers, you name it. We should be a part of your team. Within Medicare, the nice part, just to let you know, we are a different pocket of funding than PT. Okay, so you may or may not know that with Medicare outpatient coverage, you get a certain amount of funding per year and then you kind of are out of it. But occupational therapy is a different amount per year. So PT and speech carry their own funding, OT gets their own. Okay, so you should never be without occupational therapy, even if you are very high functioning and don't have any deficits. We can help you and we can monitor you throughout your whole time. So don't forget us. Even if you're not having any activities of daily living, like my objectives today were to talk to you about some of the things that I think aren't being covered in a lot of occupational therapy settings because it's relatively new in the Parkinson's world, and you may or may not have heard about it. If you have, so sorry. If you have, then great. If you haven't, then I'm happy to tell you more about it. So the first one is going to be vision, and I'm already testing your vision here. But the second one is going to be sleep. And then the third one is going to be why are your ADLs taking you so long? Okay, so let's go right into vision. How many of you guys have noticed any vision changes with Parkinson's? Any blurred vision, visual fatigue throughout the day? So you notice what are some of the visual things that you guys have noticed throughout your day? Double vision, yes, what else? Fatigue towards the end of the day? Mm-hmm. Inability to focus. When what? When you're reading? Yeah. Okay. Anything else? Seeing things on the ceiling. Uh-huh. Like hallucinations, shadows. Yes, okay. We can absolutely talk about that. So visual pain, like eye pain, yes. Okay, so here are some of the things that you may or notice. Hi. So these are some of the things in activities of daily living that the research is showing us related to vision that you may or may not be aware of. So freezing of your gait can be related to visual changes. Who knew, right? So why is it that we are freezing through the doorways or in small closed spaces? Studies are showing that that's actually because of vision. We'll talk about that a little bit. Difficulty with reading because of visual attention. It might be because of blurred vision. Blurred or double vision, especially worse towards the end of the day with visual fatigue, as you talked about. Driving complaints, so difficulty with staying in the lane. You may or may not, I'm not calling certain people out here, so it's not the purpose of this. Difficulty with staying in the lane, so you may or may not veer to the right or to the left. Typically your spouse points that out. You might not be aware of it. Some weird parking, so you may or may not come in at a different angle, or you're like, ooh, that person next to me parked weird, but that's actually you. Nighttime light sensitivity, so you have a hard time with driving at night and the car's lights seem, more bright than normal. And ocular rigidity. So you have muscles around each one of your eyes, right? 6 muscles, in fact, around each one of those eyes, and those become stiff and rigid just like every muscle in your body. All right, and so those become, the same thing happens. And your eyes become, just like your muscles, you underreach or underreach with the movements of your eyes, and they can, so you don't scan as far, just like you don't reach as far, or you don't take as big of a step. You could have difficulty in with your orientation of your clothing, so you might put on your clothing backwards. You have a hard time finding the sleeves in your shirt. Look at this. I like this. Could have done a poll. And then eye pain. So this is your eye pain, right? Your eyes hurt. They feel uncomfortable. So dry eyes, you feel like you have to have lots of eye drops, or the blepharospasms, right, where your eyes close and you have a hard time opening them, okay? So we're not going to go through all of those because that's a whole talk for a whole nother day, but we're going to talk about some of them. I just want to show you this chart, and I'm happy to share this with you. I know this is hard to read as we're doing vision. But this goes through the different types of Parkinson's and the different Parkinsonisms. So if you have an atypical Parkinson's, what you may or may not see with it. And there's positive and, there's certain types of vision changes with each type of Parkinson or Parkinsonism. So there's different things that the research is showing us. What we do know is that vision changes occur with color changes, so being able to tell the difference in blue and black, very similar colors, and contrast changes. So like looking over here, who Carly Hart is the best. I don't know who wrote that, but the colors that are very similar becomes, that dysfunction changes as early as 6 to 12 months as your first motor symptoms. All right? And you probably didn't realize that. That's very early on. I thought I was doing well with that. We had a good run for a second. So that becomes, if we think about function, that becomes things like stepping off of a sidewalk onto the concrete, right? Those colors become very similar. They look similar, but sometimes that's why you might have a hard time with judging where you are in space because those colors are so similar, okay? Or stairs. It might not necessarily be balance, and it very well could be. I'm not saying it's not. But when we talk balance issues, we always want to talk eyes too, because it could be that you're having a hard time telling the difference between what's the one level of the step or the other level of the step, because it's hard to tell that depth perception related to that. That happens as early as 6 to 12 months of your first motor symptoms, all right? This also impairs if you think about your, in the bathroom, especially late at night when you're having visual fatigue. The tile floor typically is the same color as like your toilet, right? The bottom of your toilet. So that creates messes or you have a hard time finding the toilet itself. This is debated in literature, and we're not going to go into it, but there are some studies showing that there's a possible very small ocular tremor that may or may not be, you wouldn't notice it, but that can impact reading and create blurred vision. All right. And then there's a reduced blink rate. So that's it's slowed. There's difficulties with light adaptation. So that's what we were talking about, going from bright light to dark light to bright light again. So that's your night driving. When a car comes by with a bright light on and then comes into view, and then you go into a dark and then come back. Slowed eye movements. So your reaction time for scanning, those type of things become more difficult. Impaired depth perception, so you don't feel as comfortable pulling out in front of cars because you don't have that awareness. Impaired spatial relations. Maybe you have a hard time finding things in drawers or closets, so maybe you're like, it's right there, or your spouse is saying, it's right there. I just told you it was, can you find the fork in that drawer? And you're like, I'm looking. That's all related to this. And changes in pupil reactivity. So, and then there is some mild changes in facial recognition and visual hallucinations, right? So that's seeing objects, seeing shadows. We're not going to go into the visual hallucinations today, but that is something I'm happy to answer if you'd like to talk about it later. So what can we do as OTs to help you with this? So we notice with contrast changes, so visual acuity and contrast changes, with the blurred vision, with difficulty seeing sharply. So this is, you might not say like things are blurry all the time, but just things don't look as sharp as they used to. And this is age-related changes. So sorry, it happens after the age of 40, okay? And then it gets worse with Parkinson's too. This is finding items in those busy environments. Things that we do as OTs, we look at increasing contrast around the home, all right? We might do things like such as this. We put like bright yellow lines on your stairs, and that increases the contrast, right? So I had someone who was falling outside of his house on his steps, and he had pretty good balance, so all I needed to do was put painter's tape on that step, and he was able to stop falling because it was actually vision related, right? Or if you're making a mess around the toilet, put painter's tape around the edge of the toilet. Or those lights that go inside of the toilet now, have you seen those? They're like $10. They're great. They help at night too. They work as night lights, but they go in the toilet. Oh, you guys are missing out. They're different colors, and they're green and blue. They have games for inside the toilet room too. I mean, they're great. But then they keep you from making messes, which then decreases falls. Or let's say if you're having a hard time finding items on the plate. I know that sounds really silly, but like, don't eat mashed potatoes off of a white plate. Simple things like that go a really long way. You can eat mashed potatoes off of a black plate, or use a red placemat, and it makes a huge difference in your ability to see, and it decreases that visual pain that happens towards the end of the day because your eyes are having to work extra hard. So just looking, how can you improve that contrast? The other thing is tinted glasses, and I'm not trying to promote a product, and this is going to move as soon as I take my hand off, so I apologize. But one of the things we use around the clinic is I typically try out these things called cocoon glasses. And you've probably seen these on some people, but you didn't really know what they were for. You're probably just told to get them. These type of glasses are for, they go over your glasses. And what they do is these are designed with a certain type of lens, all right? And this is called the lemon tint. And this is designed for low lit environments, so nighttime driving or in a dark restaurant. and this increases contrast. So this is what you wear when you're driving at night. You can get them from different like glasses place, like eyeglass shops. I told you it was going. It's my finger that saves the life. You're welcome. This you can get it from there. We got these on Amazon, I think, for under $30. They have different colors, so they have some for screens when you're using the computer that are blue, that changes your ability to manage the your eye pain on the computer. So you would go and look through what colors work best for you. So these don't necessarily improve your contrast in this room because it's nice and bright, but I'll just pass these around so you can see these. The other thing I'm going to show you, and it was on there, and I'll pull it back up in a second, but this is a bookmark guide. All right, you can get these for $1.09. It's an odd price, but that's what they set it at. And what this does is this is when you're reading, it decreases visual fatigue because it works like a bookmark guide. And it highlights a certain word or line for you, but it also increases the contrast of that. So if you think about reading a newspaper and the ink, it smears. So the contrast on like reading newspapers is horrible. It makes you it's a very common place to have blurred vision. Using a reading bookmark guide can decrease your visual fatigue dramatically, all right? And so these are very, very nice tools that you can get that will make a tremendous difference. Yes, ma'am? Where'd you find that? I can send you the link. It's actually a kid website, but it's called therapyshop.com, and the shop is spelled with 2 P's. So it's THERAPYSHOPPE. But I have my card over there, and I can send you these links. But they're $1.09, so they don't break the bank, which is a nice part. So I'll pass these around too. The other thing with vision on the computers is the contrast on the computers or tablets is making sure, like reading on black print with white words makes a big difference. So those type of things can increase. When we talk about visual fatigue, you talk about towards the end of the day, your eyes get tired. That makes a huge difference on decreasing the amount of work your eyes have to do, right? When you go to an OT or PT, they talk a lot about making sure you save your energy and use it for what you need. Same thing goes for your eyes. I printed out some visual hygiene handouts, and they're not the best visually. I apologize. Wasn't my doing. I used it from a source. But they talk about those type of things. Use these type of strategies throughout the day, and it can make sure that your eyes are much better off, okay? So that's on the Kindle or your tablets. This is kind of what you're looking at, that computer screen in the middle there. So eye movements. So as you can see here, over the functional deficits, this is what you see when you are bumping into items. He left me. That's so nice of him, his password. Bumping into items. This happens with visual fatigue. When you're scanning your environment, so maybe you're missing things, you constantly bump into the right side or the left side of things. You have, this is what happens. This little nice diagram is a diagram of someone showing like what your eyes do when you go to a website online and what your eyes have to do. So this is the first place your eyes look. This is the very next place. It goes all the way over here, 2, 3. So your eyes go like in this really awful pattern. And if your eyes are rigid, they're not getting that, right? So if you can imagine in a functional environment what's happening. And then there's several studies that are showing that that's what's linking to turns, like freezing with turns. So if you've been working with physical therapy for freezing, you'll know that that's why they put down lines on the floor to help with freezing, or they use that red line to help with freezing of gait. They use those U-steps so that you have to walk over it. That's all related to vision. You have to reach past it in order to help with your eye movements. You're undershooting your target. Your eyes are under aiming as well. All right, I think he's got your bookmark next to you. All right, so some things that we can do for you is visual therapy. So there are actual ways, just like you would do for your arms, is to actually move your eyes. And you never really think about it. It's just like the small joints of your fingers. We can actually help with your eye muscles. We also have compensatory strategies, so thinking really big, just like we talk about, and we're going to talk about this next, but don't just stop halfway. Really, we talk about an anchor strategy. Make sure when you're looking for something, find the wall, find the edge of it. Right? Go all the way to the far left, far right. Relearn to do like a lighthouse strategy. Scan left to right, and make sure you find an endpoint before you start over. And then again, use of a line tracker. That just makes your eyes not have to work as hard. Okay, so what happens is if one eye, I'm afraid to take my hand off on this sucker, but if one eye gets more rigid than the other and you're trying to come in the middle, let's say if your eyes are coming in together like this and one eye moves slower than the other, one eye's coming in this way, the other eye's out this way, this eye's kind of looking here and this eye's coming in the middle, it doesn't work well. So that's why when doctors do this test, they're going left to right, they're going up and down, and they ask you to look at a pin, right? And that's what they're looking at. Do your eye muscles team together, okay? Same thing here. That's when we talk about your eyes coming together, that's exactly what we're doing here. So the functional issues that we have are reading. It might look like this. It might look like double vision, or it might look just like this halo effect. So it might not look bad, but it just kind of looks like there's this extra little shadow when you're reading, and that's that visual fatigue. You might have difficulty with computer, any difficulty with leisure activities, so that might be driving, and then your eye strain or pain. So prisms can be prescribed by a neuro-ophthalmologist, which is great. So there are ophthalmologists who specialize in the neurological changes in your brain, and they look at your eyes in a different way than your ophthalmologists do. So they prescribe different types of glasses. And then vision therapy. So one of the exercises, and I'm purposely changing this right now, just to let you know. I want to show you a vision exercise so we can all try it together. This is called pencil push-ups. All right, you guys ready?
Welcome back to the Fit Body Bootcamp Madison mobility endeavor. Today in mobility class, we did not do any joint mobility whatsoever. We still got startling improvements in range of motion, decrease in pain, strength, and just the way that people move by doing simple vision exercise. So, to remind all of our campers that most of your posture and the way you move is actually determined by how well you see, I'm going to give you one exercise to start improving your vision. It's called a pencil push-up. Very simple. You can take a vision stick or your handy self-made vision stick called a finger. Put it at arm's length in front of your nose, and I'm going to bring it straight to the tip of my nose at a speed that's not too fast to startle me, and then come back out. Now what I'm doing is I'm focusing on the tip of this stick, and if it ever splits into two images, I would hold it there, breathe, and then bring it out. For me, it doesn't split, so I bring it all the way into my nose, all the way out. And if you can see on the video, you'll see my eyes straighten and then kind of come cross-eyed as they converge on this. This is a very important skill to have. And if you're lacking this skill or the image splits really bad, it can cause a lot of pain symptoms. So try that.
That helps with your eye muscles and those functional deficits that we saw with convergence. Okay. Anyone have any thoughts on that? Interesting? Think you're going to try it at home? You don't have to admit it, but we kind of do if I ask you that. That's okay. That means your eyes are doing it. But sometimes if you don't see two at all, you might want to ask your occupational therapist too to double check, because sometimes you can cheat too, and one eye just doesn't even move at all. And you don't want that to happen. All right, I'm going to go through this. We've been talking a lot. So sleep changes, as you guys all know, is a huge issue with Parkinson's. So sleep changes affect 96% of people with PD. And not only that, it affects like 50-something% of people, the caregivers as well. So it affects both motor and non-motor symptoms. Insomnia is a big part of that, so difficulties with the falling asleep aspect of that. So that's what we're going to address. We do know, well, we do know that there are non-motor symptoms. We do know that there are medications, and then there are non-pharmacological treatments, which is what we do. And that's what we also do stress management. So I've learned myself, as you can tell. There we go. Sleep hygiene has been proven to be an effective adjunct to the sleep medication that they give you. So it's very beneficial to change your sleep routine to help. So there are things like a sleep diary to figure out what you are doing with your sleep patterns to help with that insomnia or difficulties falling asleep at night. All right. I gave you a handout on sleep hygiene. Very important to take that. We all have bad sleep hygiene. And I say we all. I would pretty much assume that most of us do at some point or another. So let's talk about that. Some sleep hygiene tips for PD. Bed should only be used for sleep or for sex. You should not be reading in bed. You should not be eating in bed. You should be not watching TV in bed. None of that. You should be only using that for sleep or for sex, okay? You should have a consistent sleep and wake cycle. That means you should go to bed at the same time within an hour or so every day. You should avoid intensive, don't get me wrong, intensive exercise 1 to 2 hours before bed. There are some sleep yoga exercises, so there are some yoga positions that have been proven to help you fall asleep better, and you can do those. You do want to engage in physical activity throughout the day. If you are too tired to exercise, it doesn't count. It becomes a very nasty cycle, okay? You have to engage in exercise in order to have better sleep at night. You have to avoid all electronics. This is my weakness, right? Cell phone, tablets, computers, TV, 1 to 2 hours before bed. There's a little blue light that's emitted and you don't see it. It's not something that you're like, oh, there's a blue light. It's something that goes into your brain and it triggers their circadian rhythm and tells your brain that it's daytime. If you fall asleep with the TV on, it's because you're that tired. All right. You have to get outside and see the daytime. This is where it becomes difficult for people up north to fall asleep, right? Because if they don't see the sun at any point, or people in Alaska, they have a very hard time with their sleep-wake cycles. You have to see the difference between the day and the night. You have to ensure that your bedroom is comfortable, so you have to have a nice comfortable bed. You have to have a nice temperature in there, and if it's not, change it. You have to manage, this is a big one for Parkinson's, manage anxiety, planning, thinking at night. If that's something you struggle with, please come find me. I've got lots and lots of things you can do for that. I brought some handouts, but I'm happy to talk to you about it. But this is something that typically can keep us up for hours. We're thinking about the next day, or we have worries, right? The dopamine changes that happens with Parkinson's makes you more anxious, and then you think a lot more, and that makes you not be able to fall asleep. Avoid caffeine, alcohol, and nicotine 4 to 6 hours prior to bed. That means you can't have your wine right before bed at dinner. That's hard for a lot of people. Even though that acts as a depressant, what it does is it makes you wake up in the middle of the night. And waking up in the middle of the night makes it harder for you to go back to sleep. Avoid a heavy meal prior to bed. Snacks are okay. This is a big one. Limit naps to no more than 30 minutes during the day. All right, so if you're going to take naps, I'm a big advocate of taking rest breaks, but it has to be 15 to 30 minutes. It can be several times throughout the day, but it should not be more than 30 minutes because then it messes with your sleep cycle at night. And then follow the 15-minute rule. If you are staring at the clock or you know there's no way you're going to be asleep in 15 minutes, then you need to get out of bed and do something to help you fall asleep. So whether that's reading, sitting on the couch, doing a yoga stretch, get out of bed. Because if you're going to sit there, then you're going to be anxious and thinking about why can't you fall asleep, and then it's a nasty cycle. So we won't go over a lot of these, but there are certain things that we can't do in OT to help you with. So this REM sleep disorder where you've got those active movements, that's going to need to be medication management. All right. This excessive nighttime urination. So if you're getting up more than once, maybe twice a night, that is something that's very common. It happens with age. Women who've had had childbirth. Limit fluid intake prior to bed. But pelvic health physical therapy, I'm not sure if you've heard of this, is a phenomenal branch of physical therapy that can help decrease your need to have to go to the bathroom. That urinary frequency is common with PD, and it changes your pelvic floor, and it can make a huge difference at night, but also during the day. So it is something that is covered by insurance if you have physical therapy coverage, and it can make a huge difference. They'll teach you how to create a healthy bladder routine, ease the trip to the bathroom, so get a bedside commode. And then there are medications that can help. Oh, that one even shut me out. So there are certain things that you should pay attention to. And don't be afraid to ask your doctor about those things. Because these things need to be managed. If you do not get sleep, it won't get better. Your motor symptoms and your non-motor symptoms are going to be very much impaired. And just because you're aging doesn't mean that you can get less sleep. All right. The other thing, restless legs, make sure you get regular exercise in the late afternoon, but not 1 to 2 hours, or 1 to 3 hours, really 1 to 2 hours before bed. Stretching with that sleep yoga may help. Some studies have shown that acupuncture might help with those movements where you might move a lot, hit others in bed. And then sleep apnea, make sure you get a sleep study. NPF has a lot of great videos on sleep tips with Parkinson's on YouTube. We won't show you that, but I can send you those links if you'd like.
Getting enough rest and sleep is an important component to overall health and quality of life. Parkinson's disease creates many challenges to getting a good night's rest, both for the person with Parkinson's and the caregiver. Loss of mobility often makes it difficult for the person with Parkinson's to feel comfortable in bed, since it is hard to roll or shift position easily. Bladder changes may result in a need for frequent nighttime trips to the bathroom. PD medications and sleep disorders increase the likelihood of having bad dreams and nightmares that hinder the ability to rest well throughout the night. If the person with Parkinson's is not sleeping, it is highly likely that your sleep pattern will be disrupted as well.
We don't sleep together now because he has that REM sleeping disorder. So he's just moving all over. He's talking in his sleep, and he's, I got punched one time, so we had to I sleep in one room and he sleep in another room.
Choose a bed that is comfortable and conducive to sleep. It may be necessary to consider twin beds or sleeping in separate rooms to ensure better rest for both you and your loved one. In this case, the person with Parkinson's can use a call button, alert system, or monitor to let you know she needs help. The bed should be low enough that the person with Parkinson's can get her feet on the floor easily. Avoid high mattresses that require a step up onto a stool or platform, as this is a likely location for falling. In some cases, removing bed casters will lower the bed to a more manageable height. A half side rail or bed pole can be used as a sturdy hand grip and provide some leverage when trying to get into and out of bed. Hospital beds can also be used to make necessary adjustments more easily. They can be raised during dressing and bathing and lowered as the person tries to get up. Rolling and moving in bed can often be made easier by using a piece of slippery, satin-based fabric through the middle third of the bed so it fits under the person's shoulders and hips. Avoid flannel sheets and nightwear that add friction. These make bed movement more difficult. Some people find that removing the top sheet and using a light comforter keeps feet from becoming tangled and allows the person with Parkinson's to move more easily. A firm mattress also makes it easier to move around. Avoid water beds or too soft mattresses that hinder the person's ability to roll or move. Check out part 2 of Rest and Sleep for more tips on creating a restful environment so both you and your loved one can get the sleep you need.
All right, so aspects of PD that impair self-care. So real quickly, Addie, are you in here? Nope, she'll come in and kick me out when she's ready. So we do know with Parkinson's that rigidity, dystonia, posture changes, tremors, akinesia, this is what we're going to talk about. So the impairment of voluntary movement. So this is coming from, the basal ganglia, right? This is where your Parkinson's is kind of based off of. The basal ganglia tells you where your automatic movements come from. I kind of think of it like a gatekeeper, right? Tells you what movements are allowed and what movements aren't allowed to come from. But when you have akinesia, what it does is it requires conscious attention to a task to complete. And with Parkinson's, my guess is you probably don't want to always think about what you're doing every task of the day, do you? Maybe you can tell me if I'm wrong, but I wouldn't think you'd want to. So you don't want to think about dressing all day, right? Like I have to put my arm sleeve in and give more effort, do you? There's also the hypokinesia, so you get the reduced size of your movements, right? You get the small steps. And bradykinesia, you get the slowness of your movements. So many people tell me it just takes me longer to do things. So good news is neuroplasticity is attainable. We can manage this. Aiming big, keyword is big, not fast. Okay, so please don't hear me that I'm not saying fast, it's big, makes you faster and more accurate. So high amplitude movement training and rehab, what we do is we use these big movements. They show improvements in motor function, daily living activities, and gait. So their programs are geared towards this with the LSVT Big, which is one I'm going to talk about today because that's one I'm trained in, so I know a lot about. But power is one of those that's related to it. Am I done? Okay. I'm going to go through this real quickly, like a few minutes. Amplitude-oriented training. So the Big program is this program, you may have heard of it. It's 1 session a day, 4 days a week, for 4 weeks, 16 sessions. You have to be cautious with it. I'll talk to you about it later. But the idea behind it is, and I gave you a handout, is Parkinson's makes your movements small, right? On this scale here, here's your normal movement. So to put on a shirt normal movement's about a 3 on the effort scale. Parkinson's makes your movement small, and you don't realize it because your sensory feedback system's impaired on a 2. You have to purposely override that and think big, much higher effort to balance it out to make it normal. All right? Once you start doing that, the neuroplasticity becomes more appropriate. So instead of aiming for, and that's just the slide. Let's do this. So for example, writing big, when you get small writing, it's partly because of, there's several factors going into it, but aim big, aim from top to bottom of those lines. There's nothing saying you can't do it, but because the feedback system's saying small, go from top to bottom. Go back to those days in elementary school where you were told you had to touch top to bottom line. Aim big again.
All right, welcome everybody to the Haven Home Health and Therapy LSVT Big Home Exercise Program Volume 2. This is Amelia. She's going to help you go through your exercises. We're going to start with reaching from floor to ceiling. Here we go. 1. We're reaching big, super big. 2. Out, down to the floor, up to the ceiling, out to the side. 3. Reach big. 4. Very good. Now, we're going to reach to the side. We're going to do 4 of these. Here we go. 1. 2. Reach big. Very good. 3. 4. Very good. The other side. Here we go. 1. 2. 3. 4. Very good. Now we're going to do our standing exercises. We'll start with the forward step. We're going to do 4 of these. Here we go. 1. Step big. 2. 3. 4. Other side. 1. 2. 3. 4. Very good. Now we're going to step out to the side. We're going to do 4 of these. Here we go. 1. 2. 3. 4. Now other side. Here we go. 1. 2. 3. 4. Very good. Now we're going to step backwards. Here we go. 1. 2. 3. 4. Other side. Here we go. 1. 2. 3. 4. Very good. Now we're going to do the forward rock and reach. We're going to do 10 of these. Here we go. Reach big. 1. 2. 3. 4. 5. 6. 7. 8. 9. 10. Good. Switch feet. 1. 2. 3. 4, 5, 6, 7, 8, 9, 10. Good. Now we're going to do the sideways rock and reach. Here we go. We're going to do 10 of these. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. Other side. Here we go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. Now we're going to do our sit to stands. We're going to sit and stand really big. Here we go. We're going to do 5 of these. Stand super big. 1, 2, 3, 4, 5, 6. Very good. Thank you, Amelia. And thank you from Haven Home Health and Therapy.
All right. When you are doing, well, the last one I'll show you, like when you're putting on a shirt, make sure you pull that arm sleeve all the way up to your armpit, right? Don't stop here and then pull over your shirt, because then you'll always get stuck. And then you do the shimmy movement, and then you're doing this, and then you have a hard time putting it on, right? I know all of you, your laughs, but I know it happens. You have to think big posture and change that, and that will make a difference, okay? So these programs of high amplitude have shown a lot of support in changing the neuroplasticity in the brain. It doesn't have to be big. It can just be teaching you to think big, makes your daily activities go much quicker, okay? So you ask your occupational therapist, your physical therapist, how to incorporate throughout your activities, and it will make a huge functional change for you. All right, so I put a couple of handouts over, well, I put a lot of handouts over there, and my card. I know I went through a lot today, but please shoot me an email. I'd love to talk to you about some of these things that you may or may not have heard of before, okay? Thank you for bearing with me through this hot mess of a slide, and let me know if you have any questions.